So folks, we might kick off now. It's just on 7 o'clock. So on behalf of Rural Nurses New Zealand, I'd like to welcome you. My name is Mark Eager. I'm from the team of Mobile Health, and I'd like to introduce Maria Kekus. Despite the name on the bottom saying Pauline Proud, Pauline is in the background and she's from one of our team members. So Maria, can I throw over to you, and if you could start your presentation.
Hello everybody and welcome. It's a privilege to be here this evening and thank you for staying up so late. It's great to be here. Look, I'm just going to remind you what we're going to be covering tonight, which is we're going to be talking about the HEEADSSS framework, which is a tool that we use to assist our work working alongside young people. We're going to look at why we're going to use it, what it actually is and how to use it. So I'll get started, I think. One thing, and thank you, Mark, for one of the things I'd like to make sure is that I cover what you need through this session. So if you do have anything that I'm not covering and you want to talk about, either ask the question or write it down and we'll try and cover it at the end. Okay, so the why. Why do we use this? Now, I'm sure you're all in front of this screen tonight because you're working with young people and you've had some good opportunities, some good experiences, but also some negative experiences. And I thought before we get into the HEEADSSS framework, we'll talk about why work differently with young people and how to understand young people. So I'll just let you to reflect on this for a minute, and I obviously can't get you to answer, but I'll just read through that and think about who has said this and when was it said. I'm not going to read it to you because I'm sure you can read it. Now, I'm sure you can all think that it's something that could be quite recent or something that was said yesterday, but actually this was said in 800 BC. So for a long, long time, working with young people, or young people are presented with issues where they've challenged people, challenged behaviour, had challenging behaviours and challenged elders. So it's nothing new. So we work with young people because we see them as their resources to develop, not problems to be solved. They're our future. They're transitioning from childhood into adulthood, and they do have a specific developmental stage. So this quotes come from Karen Pittman, and I think it's really important to understand what messages we see about young people in the media. Now, I'm just going to show you some of the negative ones. This is from recent newspaper articles. That young people are taking drugs, young people are addicted to booze, they assault people, there's lots of problems. And there are probably many more. You can probably think about your local papers, something you've read recently, that these stories and negative images in the media pop up regularly about young people. But there's another side to them as well. Young people have some positive stories to tell. I mean, you'll all recognise Greta from the climate change movement. They are leaders and they are future leaders, and actually, they're going to look after us when we get older as well. So we want to ensure young people transition from childhood to adulthood in a pro-social, strength-based way. So who are young people? And I think one of the challenges is they get many definitions. They're defined by their chronological age, and World Health Organization defines adolescents as 10 to 19-year-olds, youth as 15 to 24, and young people from 10 to 24. So there we go. We start with not a clear definition of who young people are. Add in social definitions. So I'm sure that most people think young people are adults at 16, for example, because they can leave school, but that isn't the case. There are so many different social definitions for young people. We have cultural definitions. One of the Pacific nurses I work with tells me she was not an adult until she had her first child. So overlaying the chronological, the social, the cultural, we have physical things, the physiology and the biology of puberty. Do we become adults when we can reproduce? And if you look at other cultures, that does happen. They have puberty rights and then they become adults. And then there's the legal definitions, and here it throws us into a bit of a spin tail, because what age can you leave school? 16. What age can you have sex? 16. What age can you vote? Oh, 18. What age can you drink and smoke? 18. What age can you get a student loan? And we could jump up to 25. So you can be independent and do all these things at 16 or 18, but to actually be a student, you have to have your parents sign your loan for your student loan. So we're giving young people mixed messages. We don't have transitions and definitions from childhood into adulthood. So what I'm going to look at now is just to explore what the difference between adolescent and youth development is. I'll give you a minute to look at my lovely cartoon. So you'll hear me use this quite a lot. When I'm talking about adolescent development, I'm talking about the physical and the physical development. When I'm talking about youth development, I'm relating to how young people transition from child to adulthood through the social norms of the society they live in. So I've got some very full slides here, guys, and I think it's just to give you some frame of reference as a resource as well. So what we know is we talk about development, physical development in 3 stages for adolescents. So the early stages are 10 to 13, middle 14 to 17, and the late is 17 plus. And nothing new there, you're all nurses or health professionals and you understand that. But I think what's really interesting, and this is really important when you're framing up your assessments, whether it be your HEEADSS framework, or you're doing a clinical assessment, or doing an immunisation, or whatever you might be doing, is to think about the young person you have in front of you and where they fit in this developmental stage. So working with young people who are 10 to 13, need really clear instructions. Take your medicine, breakfast, dinner and tea. You work with a 17-year-old whose cognitive development is a bit more developed and they can synthesize more complex information. So you could say, take your medications 3 times a day. So it's a really simple example, but a really important thing, because if you said to a 10 to 13-year-old, take your medications 3 times a day, you've lost them. You know, that concept is not always that easy to actually understand for them. So some of the major development issues these 3 age groups face are listed here, and I know I'm shooting through them a little bit fast, but I'm hoping you'll get access to this later. The early stages are my normal. The middle stages are really situated around who am I and where do I belong, and this is that phase, that middle adolescence, where we do see a lot more risk taking. Relationships have become very self-centered, and for those of you who are parents will probably recognize this. It's me, 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 and the peer group is really important. And actually the whole purpose of growing into an adult in puberty is about that sexual development to become a sexual being. So you've got the emergence of sexual identity, and at this point during this phase, the sexual identity can veer from, you know, heterosexual to same-sex attraction to asexual. All sorts of things go through young people's minds. So, and then the later stages is around that independence from parents. Now, one of the things we always used to talk about around adolescent development was that young people need to separate from their parents. But what we actually know is that is not the case. Where young people do really well is when they're well connected to the parents through this period of time. And what's really interesting when I'm working with parents who are struggling with adolescent behaviour is I say you actually need to be around the home as probably sometimes as much here at this stage as you do when you've got a toddler, because they need that guidance and consistency and boundaries. So here we have the acceptance of their sexual identity. They're starting to set goals and plans. So you work with a 14 to 17-year-old, they're not very good at planning. They're a little bit all over the place and a bit chaotic. And they're generally at 17 years plus, they are a little bit more focused and more responsible. I think I need to add a proviso. This is like a nice stepped approach, but young people don't always follow this stepped approach. You add alcohol and drugs into this mixture, or you add low mood and depression into this mixture, and young people can move in and out of these stages. They don't always transition so neatly and nicely. And just some more things. Oh, hang on, no, sorry, we'll move on to this. One thing that we do know, and it's, you know, we do know about brain development. We used to focus on some of the theorists of adolescent development, where, you know, the Freuds and all the other theorists. What we do now know is about brain development, and we do know that the brain at this stage can rapidly lay down new neural pathways. So it's a period of time that we can actually do some change. And I've just actually yesterday read some recent research that came out of the States that talked about actually that the trauma children experience in those first 5 years of life can actually be turned around through this period of time as well. Because, you know, often we think, you know, we talk about set behaviours and set paths for children and young people that have experienced trauma and abuse in those early years. What we do know now is that we can turn that away with these neural pathway developments. So what we do know about the brain development at this stage is that the frontal lobe does not really complete until 20-something. We reckon about 25, but you know, you may all sit there and say, well, actually it's a bit later, but that's where the premise sits, is 25. I think that frontal lobe supports the ability to make sound judgments, to control impulse control, and the ability to plan ahead. Like I said earlier, if you add alcohol into this, those 3 areas of ability to make sound judgment, control impulses, and plan ahead go out the window. It's the CEO of brain development, planning, and judgment, and it's really important, but it doesn't always happen so smoothly as well. So just
Maria, sorry, could I just interrupt? We've had a few new people join us. Just a reminder to join the chat. We've got some good, a good breadth of people from all over the country, from Invercargill to Northland at the moment.
Hi.
And they're interesting. A number of people are working in schools, doing assessment on Year 9s. Rheumatic fever coordinator from Auckland, and general interest, but schools are a focus. So the new people that have just joined us, please go onto the chat and just add where you're from and also what circumstance you're working and why you're here, if you wouldn't mind. Sorry, Maria, back to you.
That's okay.
No questions at the moment.
Okay, you just joined me at the summary of the stages of adolescent development. So early development is that self-focus, moving away from childhood. Middle is searching for identity and wanting to belong. And later stages are integrating complex ideas. And when you're working, whether it be in schools or whatever interaction you have with a young person, you need to look at these stages because it does have implications for your practice and how you approach your practice. Okay? So why it's so important. Now, one thing I'm going to touch on, this is a really nice diagram. I love this diagram, and I base a lot of my practice on this because it's a piece of work that was developed by Robert Blum. He's a pediatrician and a psychiatrist in the States, and he looked at what made young people thrive and survive. And there's lots of theories around this, but this is a really nice, simple tool to use when you're working with young people, particularly young people who might present in school clinics with high risks. They're taking risks around sex and drugs and things. And what you need to think about is who are the people around them. And if they've got an adult that cares, they feel their parents care, they might have a teacher that cares or a coach that cares, they are likely to do better than an adolescent that doesn't. If they've got a place to belong, so if they're at school, your young people at school are doing really well because they're connected to school, because they're turning up and presenting. And you know, if they're participating in church, it's another place to go and to belong as well. So this is a really high level summary of that youth development model that I'm talking about, but to go into it could take a few days. Activities, so school is an activity, but belonging to a sports team, playing an instrument, going to guides, whatever, you know, scouts, anything that creates a an ability to have activities that give them the sense of belonging and connectedness. And contributing, the opportunity to contribute to family and the neighbourhood and community. And this is often a really interesting one. And one measure I do, a really simple thing is, I ask them when I'm working with young people, when did you last make your mum a cup of tea? You know, something like that is as simple, because it shows that they're contributing to and thinking about other people in their adults. And it shows that they've got some pro-social thoughts around youth development, and they're on that stepped approach to making some good choices. So they call it the PCAP model. That's people who care, opportunities to contribute, activities to participate, and places to do them. So I think when you're looking at a young person, you're working with them, these are something you can think about and overlay your assessment on. Now, I can hear some of the school nurses and other people thinking, how do we fit all this in an assessment? And I'll get to that a little bit later. Young people, youth development is a period of time where young people will take risks, they're building resiliency, and there are protective factors around that protect them. And I've summarised these here. And I think, again, this is that theory of youth development. It's we all can bounce back from young people. Resilience is the human capacity to bounce back from bad experiences despite hard things. Risk-taking assists in identity formation. So young people, it's okay to take risks. It's not okay when they take risks that get them into trouble. And it's usually those risks that get them into trouble is when they're with peers that are actually using drugs and alcohol. But mostly risk-taking is part of that normal development process. Protective factors are basically those four things I talked about in the PCAP model. The protective factors are found to moderate and buffer any risk-taking. So if young people are taking lots of risks, so for example, I might be working with a young person who is going to school, missing a little bit, doing a bit of smoking dope with his mates, socially at the weekend, and is beginning to develop sexual relationships, but is using condoms. So I'm looking at that young person and I'm thinking, well, there's some risk taking there, but actually the young person's going to school and he talks favourably out, he feels he belongs in the family and he can contribute, and he might be beginning a sexual activity, but he's actually talking about that and asking for help, or condoms, for example. So for that young person, you can see that the family is a protective factor and the school is a protective factor, and yes, he's taking risks about smoking some marijuana, but he's not doing it every day to get through. He's not using it as a self-medication tool to get through the day. He's using it in a social context. And whilst as parents and health professionals we might not like that, what we're looking at is to minimise the harm rather than completely eradicate the harm, because sometimes all you do is push a young person away. Okay, so that's youth development in a nutshell. I've talked about that. It's important because it's going to help you understand what changes young people are going through. It helps you consider what might happen next to the young person, and it helps to explain their actions and thoughts. Young people are not behaving in a bad way or a difficult way on purpose. Often there's an underlying cause for that, it's development, and it can be the environment that's impacting on it. And it helps you, if you understand youth development, how to guide your plans, your healthcare plans, or whatever activities you might need the young person to participate in. So setting yourself up for a successful youth health consultation, if you identify the risk and resiliency factors in a young person's life, it helps you work better with them. Okay? I'm not going to go over too much around this data about youth health in New Zealand, because from what Mark said, most of you come from a health background, you're nurses or other medical practitioners. And I'm sure you know what the issues are for our young people in New Zealand. So I will just summarise them. I've put a little reference in at the end of this section about where to go for current data. What's of concern in New Zealand for us working with young people is that 28.6% of young people have a diagnosed mental health disorder. Of those 18-year-olds with a mental health disorder, we found that 40% of them have another disorder, that either be alcohol and drug misuse or a conduct disorder. And we do know about the youth suicide rate in New Zealand, particularly in the 15 to 19-year-olds in this last year. Our data has often talked about that the 18 to 25-year-old, but actually we've seen a little increase in that 15 to 19-year-old, which is of concern. Under 25 have a disproportionate burden of sexually transmitted infections, high rates of STIs that's seen in the 15 to 24-year-olds, and chlamydia was the most commonly one. Nothing of this is new. 1 in 4 young people are drinking at levels that were hazardous to their health, and we've got young people, 21% of them who are obese in the last survey, And adjusting for age, sex and ethnic differences, we do know that young people are 1.5 more times likely to be obese when they live in deprived areas. So we do have some significant health issues with our young people. Now, sources and good sources of data come from some of these areas. Now, the Youth 2000 has actually been a Youth 19 survey, and we should be getting new data out next year. And what's great about this, it's a longitudinal study, so we're starting to see trends and things emerge, which is great. So, I suggest you do check that out. A lot of the data has come from the New Zealand Health Survey, and some of the sexual health data has come from the Sexual and Reproductive Health Survey that has just recently been produced. It's a 24 survey, but it was released in October, I think, so check that out. So I'm sure what you're seeing is no different to me. You'll see some of those common mental health, common presentations around sore throats, ear, nose and throat issues, injuries and accidents, and you'll be seeing young people for immunisations as well in some of your practices. But actually overlying those, what we do know is most young people will have another issue that's related to some of those common core youth health issues that we see around mental health, sexual health, and alcohol and other drugs at some level of the spectrum. Okay. So whilst most young people are healthy, we do have this. I've just summarised this. What's positive and what we've seen in that longitudinal Youth 2000 survey has that young people do want to make healthy changes, and they do try. We're also seeing emerging issues around social media and online porn and gaming issues having an effect on people's emotional and mental health. What's really interesting, I was talking to a colleague, Terry Fleming, who does a lot of work in the e-therapy and the online work around mental health. But what we're also seeing emerging is that actually some of that gaming can be protective of a young person's mental health because it's their way of releasing. So you've got to temper your work when you're doing an assessment and you're picking up that young people are using a lot of gaming. It's about control and measure around the amount that they're having access to. And why young people don't use and talk about their sexual health and mental health is they don't want to make a fuss. And I can't tell you, I did some research for my master's around young people and their sexual and reproductive health, and it's really funny. They'll talk about everything but sexual health. But another positive is there has been improvements. What impacts on poor outcomes for young people is when they're living in poverty. So where we saw in some of the Youth 2000 survey, the last survey was that where poverty and no jobs for parents were, where parents were under pressure from their socioeconomic status, we saw poor outcomes for the young people. So what is HEADS? I'm getting there eventually. I'm sure for those working in school-based health services, Year 9 HEADS assessment, as it gets called, is something you do all the time, and you have that time and space to do it. Just for those who don't know HEADS, I think just talking a little bit about the history about it would be really useful. So HEADS was developed by actually 2 paediatricians, and what they realised was they were having these interactions and consultations with young people, but they were never getting on top of what the problem was in young people's mental health, or young people's, they might be controlling their diabetes, but they couldn't get control. And what the paediatricians found was that they were missing part of the picture of the young person's life. So they looked at what was important to young people from a psychosocial perspective, and they looked at elements that impacted on young people's life, and they pulled out these 1, 2, 3. How many elements we've got there? The HEADS acronym. And they've actually developed it. It's not a validated tool. It is a guide, it is a framework to base your practice on. And I do get a little bit concerned when we start calling it HEADS assessment. I know it's got a life of its own, but I think what you need to think about, this is a framework to guide your practice. You bring all your other clinical skills, and your nursing skills, your medical skills to the picture as well. It doesn't replace it, but it does set the scene to really understand what young people's issues are. And I think without doing that psychosocial assessment, and I wish you get to use it if you haven't used it, and for those who've used it, it might be good to hear your feedback as how effective it is, because young people do respond to it. It's not a tick box, and it is a skill that you need to learn, and I'll talk about how to use it in a minute. Okay, I'm just wondering if we need to pause there for any questions. Have we got any questions, Mark? I can't hear you. He's talking. You've got your. Can't hear. He's got his speaker on. Mark, if you can
Oh,
hear
sorry, I
back
apologise.
there.
Technology gets everywhere. There are no questions at the moment, Maria.
Oh, that's good. I must be answering them all.
I think you are. You're doing very well, and we've got more people online, more people from South Canterbury, West Coast.
Yeah.
So everyone's going. So you continue, and I'll go back on mute.
So, you know, the HEADSSS process is it's a framework to base your communication on. So Mark's also mentioned this, you might see some with an extra S, you might see some with a C at the beginning. So it has evolved a little bit. So when I first started using HEADS, it has HEADSS. I think that was it, S, 2 S's. We've added an extra E in and we've added an extra S on. And the C sometimes at the beginning is, sometimes people put it on for culture to identify where a young person's from, who they identify as. I personally feel that culture has to be threaded and embedded in everything we do. And I think that's how I choose to use it, but I do know some agencies do that. And the extra S at the end is often around spirituality. So, but again, spirituality sits around that culture and that sense of who they are and where they belong and how they fit. So that spirituality component can be threaded through as well. So this, if you see and you look at the updated version of HEADS, which as a reference at the end of the presentation, you'll see this is the acronym that they use. So it stands for home, education or employment, eating, activities, drugs and alcohol, sexuality and sexual health and reproduction, suicide and depression and mental health, and safety. And that is as straightforward as it is. Now, what I will do next is, I think one of the things I'll talk about is when I go into how to use it, I'll go into more detail of those, but I just thought I'd set the scene about where it came from. It's not a validated tool. It's been developed by doctors, but it actually has evolved and taken a life of its own, and it is well used across the youth sector, not just here in New Zealand, but in Australia, in Europe, and in the States as well. Okay, to use the HEADS framework, one of the things I think is really important, and you'll be experiencing this as health professionals, is how you engage with young people. And I think that's really important. I think one of the really important things about youth engagements is young people can spot if you're not genuine. They don't care what you know until you show them that you care. So you've got to be yourself. You've got to be approachable. It doesn't matter what you look like, what age you are. You've got to be who you are. And I think that tempers your language when you talk about things like sexual health and things like that. The language they may use, you may not use, but use the language you're comfortable with, because they can spot you a mile off if you're not using language that's approachable, that's comfortable for you. Be approachable, all these skills you know about. Listen, I can't underestimate that enough. Listen, be professional, and you know, some people will use slang and start talking like young people, but they're not looking for that. What we know from the research is young people want to, when they come in to see a health professional, they want to be a health professional and be strengths-based. So what does that mean? And I think this is what we do with all our patients. If you work in primary care or if you work in a school base, you actually want them to be active participants in the process and in their health journey. This is not about us telling them what to do. And this can be challenging, because sometimes you actually want to tell them what to do, because that's what we're good at as health professionals. You want to give them advice and guide them, but you've got to just really pull back and work out where their strengths are and how you can build them. It's amazing. You know, I've only ever been in one consultation where I have started a conversation with a young person and not being able to you can usually identify something that they enjoy or they're good at. And I was working with a young person who was quite depressed, and you know, hair down over the eyes, head down, no eye contact. And it does take a little bit of work. And what I say, and there's all these softer skills we can use around moving on to a different, using brief interventions and, you know, a motivational approach, but don't try battering somebody with, you know, trying to get the answers you think you want. Change the subject, talk about something else, talk about how they got to that appointment, talk about who came with them and who they are. So you take the emphasis away from them. So utilize what resource you might have in the room, whether it be another person who's come with them or where you're working from. the strengths, they do foster the motivation, and they do help young people grow. And the strengths can be internal and environmental. And like I say, with this young person, it was really hard to find some internal strengths that he had, but it is possible. Okay. So, how do you demonstrate it? You believe in them. You find something. I think I've talked about this. You find something that they're good at, and you tell them they're good at. And one of the things I often finish my consultation with is just acknowledge the skills that they've brought to it and how they've communicated what they've needed. It doesn't always start off like that, but by the end of a consultation, you can really elicit and build and draw out what's inside the young person. One of the things that we're really good at is looking at problems and not looking at what's behind them. And I think that's another thing to pull out is, you might see the young person smoking marijuana every day, but what you want to do is understand what is causing that young person to need to do that every day.
Maria, just a question. Just around these skills, I mean, I imagine you have to practice them and get better and better and better at them. And often when I've done these things before, you think you've got better yourself, but it's peer review that do it. Do you do this with in a teaching situation with a colleague around and give feedback?
Yeah, I think, one of the things we do when we teach in HEEADSSS is we often do role play. And that's a really good way to do that. And when we get to the HEEADSSS questions, what I'll talk about is practice the questions, practice doing that. Talk about what's not gone so well in your peer review, and talk about what's gone well, because this is where you learn. And I think I've had the privilege to work alongside some amazing clinicians in my work in specialist youth clinics as well as primary care. And, I've learned so much from my peers around that and from young people about how to approach things. So, peer review and pace review is a really good process.
And practice on your kids.
Role plays.
Practice on your kids.
Practice on your kids, yeah. Well, actually, that's really interesting because you can do. And actually, if you practice on your own children, it really teaches you to stop and listen. And you might want to tell them to clear up their room. But actually, is their room their space or is it yours? How many battles do parents have? What is the real issue here? And is it a problem or not? And teach them to, to show that they can, that there is a future. I'm really relieved when I'm working with a young person who looks depressed, acts depressed, and this really has a flat effect. And the Kesslers and the PHQ-9s are really, poor scores. But actually, when they've got some future goal and their future focus, it's a bit of a relief to me, because that is, this is why it's important alongside your clinical skills to understand that their future orientation have got some goals beyond this immediate time. And I think whatever you do, you've got to give it time and you've got to persist. Don't give up on young people. And I'll tell you about one of the times I was working at a specialist clinic out in West Auckland, and a mum, I could see the young person coming down the driveway to the clinic. And I thought, this young boy doesn't look like he's about 13. He didn't want to be there. You could tell by the dragging his heels coming down the driveway. Anyway, he came in and we did our intros and talked about why we were there and that we were there for the young person and that they had a choice to be there or not. So he said, I've got a choice, I can go. I said, yes, you can go. So he gets up and goes, much to his mum's dismay. But that was a good thing, because actually he chose to do what he wanted to do. I spoke to mum and spent some time with mum, and he came back and engaged with us. But it's about, sometimes these young people never do get a chance to make a choice. Everything's done to them, and what we're trying to do in this transition from childhood to adulthood is grow them into functioning pro-social adults that can, that can make choice, that can make decisions and move forward. I'm getting there. Another big important thing, and this is what young people tell us, that the reason why they don't always tell health professional things is around the consent and confidentiality. So if you're working in a school even, we've had feedback in schools that they're not always certain that the guidance counsellor or the nurse is going to be confidential. So, and general practices, if they go to a general practice and the whole family is registered there, it's a concern to the young person. This has come out from the Youth 2000 data. So talking about consent and confidentiality is really important. I think one thing I always do as well is when I'm working with young people who've been to see specialists, I'll often say, so who did you see? And they go, I don't know, I didn't know the name. So that engagement bit is really important for them to understand who you are as well and what your name is. Because if, you know, I think if they can walk away understanding what your role is and what your name is, and the consent and confidentiality, you've won in the first session. Anyway, so we all know what consent is. But again, you've got to think about that in the context of their developmental stages as well. Now, there's lots of information out there about consent and confidentiality, but you will be aware of the Gillick Competency. So, and I mentioned this around sexual and reproductive health because I do think as health professionals we need to be aware of this and how we support them, young people to access sexual and reproductive health support. But this, and I won't go over it too much, but basically it was a mum who took a doctor to court in the UK because the doctor had given her daughter a pill and she felt that the doctor shouldn't have done that. So apologies if you've all heard this before, but I think it's important to understand. So basically that was basically, it came out in favour of the doctor because what they deemed was the young person was understood what she was looking for, and she got what she needed. She had the maturity to understand it, and also she was going to continue to have sex regardless of whether she got the pill or not. So it was to do no harm as well. And so it went through, and we now have the Fraser Guidelines, which actually guides us. Now, one thing if you're working in school health, and I know often you can be in isolated roles, is to use this Fraser Guidelines when you're working with young people and document it that you've looked at the Fraser Guidelines and you've deemed that they're competent to consent for whatever treatment you might be doing against these. So it supports you. And I don't want to focus on the negative, but having been to court in care and protection cases and things like this, it's really important how we document things when we're working with, particularly with under 16s. So, can young people consent to healthcare, and what can they consent to? So, as we know, the Guardianship Act over 16s can consent to healthcare procedures, but under 16, they can, under this repeal of Section 3 of the Contraception and Abortion Act, to get access to contraception and abortion. Now, what's really interesting is it goes against, oh, I missed that slide, sorry, I've taken that slide. It goes against some of the laws that we have. So young people under 16 can consent if they're Fraser competent. So I think what we can sometimes do is hide behind some of the legalities, but actually one thing I found out in the last month is that an under 16 can enrol in a practice as well and don't need a parental signature. Now, if you're in general practice, you might go, well, actually that's not right, because we do get parental signatures, but actually we've been up to the Ministry of Health and there's nothing that stipulates it, and there's no legal parameters around it that young people under 16 can't enrol with a general practice. So there are lots of things. I think the other thing is young people can take away consent as well as give it. So you've always got to check in, and it's something that I do regularly, that they understand what we're doing. Confidentiality sits around 3 harms, and I'll just skip over this so we can get to the heads bit. And this is something I repeat, and I cannot underestimate it. And those people working in school health, I think this is something that's really important. You will keep things confidential unless young people disguise that they're going to harm themselves, harm others, or somebody's harming them. And it's non-negotiable. And it's always really good when you've done this and you've documented and you repeat it and somebody does tell you something. Remember that time that we talked about confidentiality in the 3 harms? This is that time that I need to talk to somebody. And it always makes it easy. They can get angry with you, but it does make it easy if you can reiterate that. Okay, any questions? Must be answering them all.
You're doing very well, no?
Okay, now we're getting on to the heads and how to use the heads. We've talked about this and we've talked about the framework, and I'll go through some questions with you, but I think one thing, and you'll look at this and think, well, how did it get developed? It starts with what potentially could be an easy topic to cover. So we start with home, which generally young people have a home that they live in and they have some concept of home, and it works through some easier conversational questions which are around employment or education, eating and activities, and we get a bit harder, drugs and alcohol, sexuality, suicide, depression, and safety is in there as well. Now, just to remind you, when you're asking these questions, not all young people are safe at home. So when you're asking the home question, this is about understanding who lives at home. We can start with some questions, but you might know that home isn't safe, and that's why they've come to see you, or the guidance counsellor's told you that they're seeing them because of some violence, family violence. It might not be the best place to start. You could start with school. So the structure is there to move it from the easy to the hard, but it doesn't always follow so neatly as that.
Maria, just a question around that. What's normal for some person? They may describe, when you ask a question about home, home they may see as, what is normal for them, but getting them to describe home in the way you see it, about who lives there, the relationships, the behaviours, that would be very important as well.
Yes, and I'll give you some questions. We'll go through some of the questions. I think it is really important. I think when you're using the heads, it's really important to ask open-ended questions and not leading questions, and ask questions even if you know the answer. And we'll talk about that a little bit in a moment. But I think it's about, is this invasive? Does it? It'd be good to hear anybody's experience of being using it. Because what I find is, if you frame it like a conversation, it doesn't feel like they're being assessed and questioned. And I'll often set it up. I just need to really help you. I just need to understand and get a snapshot of what's going on in your life, because that can help us work together to, come up with some solutions to support you for whatever you've come for. So it is really important to set that scene. I think the other thing that I hear and get feedback from is there's a lot here to cover, and when I go over some of the questions I put in, you'll think, oh, that's too much, I only have a certain amount of time. But my challenge to you, wherever you practice, is to incorporate this into what you're doing. So if you're a practice nurse and you're doing a Gardasil immunisation, this is a great opportunity to check in with a young person. If you're a school nurse and you're doing year 9, you've got the time protected to do that. But if you're a GP and you're working and you've got somebody coming in with a sore throat, it does sometimes think, well, how can I get on to talking about, I don't know, home education, sex and whatever. But actually, if you think about your practice, often as a general practice or a practice nurse, you've known this young person from being a child, so you've got some of that history. So you build on the history that you've got around that psychosocial assessment and go to the bits you don't know. So what's really interesting is, I'll put this slide up here, somebody comes in for a 15-year-old girl, you come in with a sore throat and the doctor starts asking you about sex. And this is a case that was, where, mother was, that's really important when we talk about setting the scene and talking about privacy and consent and confidentiality and engagement. It's about talking about setting the scene. So if you're in general practice, say, okay, mom, dad, whoever's the young person with, we're going to start teaching young people to be good users of primary care services, and there's some questions that would be really good to ask with you, but there'll also be some that we would ask with the young person. But be rest assured, if there's any risk or any danger or whatever, we'll talk about that as well as a group. So it's setting yourself up to be successful. And you talk about, young people are experiencing all sorts of things they're going through, from, so they're changing through puberty, so use words that people are comfortable with. If parents are better with puberty than sex, But I think the bottom line is, if health professionals, as a health professional, are not asking, if parents are not asking, where are young people getting this information from, and where are they getting their support from? And I think, you've got to give it a go, even though it might risk being on the front page of the paper, but it's how you frame up that process and why you want to see the young person on their own as well. So just as a reminder, strength-based questions, open-ended, and I'm sure you all know what they are. So, do you go to school? You're going to get a yes or no. Which school do you go to? At least you get where they're going to school, So it's questions like that. Talked about this. Do ask, even if you think you know the answer, because sometimes they surprise you. If you don't ask, they will not tell you. And I think this is a challenge to us as health professionals. We are, we do need to ask. We do know we have high rates of STIs. So a young person coming through your door at 15, a young woman is likely, and she's got a sexual partner, potentially she needs an STI screen. So if we don't do the asking, where's she going to get it from? I work in a youth justice facility, and we have something like 30% of the young people come in with a chlamydia infection. We have gonorrhea, we have all sorts, and it's not like they've just got it recently, they've had it for a long time. So, that young people are not great users of primary care services, which is great why we've got school-based services, because there's the potential there to access it. Be aware of your own assumptions. Don't assume. So don't assume things like same sex, opposite sex, just talk about partners rather than if you've got a boyfriend or a girlfriend, or if you do that, if you've got a boyfriend or a girlfriend, remember to be aware of our rainbow young people, that LGBTI, that's it, lesbian, gay, bisexual, transgender, intersex. So be mindful of that, particularly if you're working with that middle adolescent group, because actually if they're questioning that and you say, you say it's got a young man in front of you, ask if it's got a girlfriend, then it starts putting your assumption that this is normal for them and they should have a girlfriend and it's abnormal not. And we do know that we have higher rates of young people who are same-sex attracted attempting and unfortunately completing suicide. So really important about how you approach these things. And I can't stress this enough, give it a go because it does work. So, some questions. And I put them in because I don't know how to interact on this medium with you, but I think this just gives a few questions that you could add. Now, I don't know if anybody has got any other questions that they found really work. Any of the school nurses who are doing Year 9 HEEADSSS assessments. And this is where I've got lots of questions, but actually, you can condense this and build on it every time you see a young person, so you work with what's important. One of the questions I do like to ask is who makes the rules at home, and that's really an interesting thing because actually it's often mothers, which is really interesting, but it is important. We like rules in adolescent health and youth health. We do like rules. Rules are good. Boundaries are good for young people. And I'll often add, do you think they're fair? Because it gives you an understanding of, what's that like, and what are the consequences if you break the rules. That's always good because it gives you that insight into how people are managing bad behaviours at home. Because it is a tricky time parenting adolescents, and I've talked about some of the extremes of young people around, quite significant drug and alcohol use, but even though, the ones who are connected to school, who've got places to be, they contribute to society, they've got activities participation, and they've got a really caring home, still struggle because of that whole adolescent development phase of all the physical and cognitive changes they're going through. So there's some of the questions around school and home. I don't know, anybody got anything else to offer from the group? No questions? Okay. School is important, and I think one of the things, it's okay to ask about how they're doing and what their grades are. And I've even worked in general practice, and I've been working with a young person and with their family, and I've asked them to bring the school reporting because it gives me a picture of what's going on. So utilise other resources, other partners, other professional relationships that can help you, particularly if you've got a young person in front of you who potentially refusing to go to school, they've got low mood, parents can't get them motivated to do anything. They might be presented with repeated abdominal problems because, they're somatizing. These young people we need to understand what's going on and the barriers to going to school. And one of the things I've done quite often in schools is work to succeed. So if you're a person struggling to go to school, don't make them go to school and finish halfway through the week if they can only do half a week. Get them to go to the latter half so they finish on a Friday and have that sense of achievement that they've succeeded and got through the week, or get them to go to the end of the day. And negotiate these things with schools. So if you're a school nurse, these are really important strategies that you can try. Working's good, and also I do often ask about what do you want to do when you leave school. And this is great, a great opportunity when I say I'm going to be a rugby player, and I'll show you how I use that later on. Eating's good, families who eat together stay together, and young people, it's a good resiliency. We do know that they're healthier and they have better body mass indexes when they eat together. But we do have a lot of young women and men actually who are very stressed about their body shape, and I've put some questions in there to address obesity, but framing it from a different perspective. So what do you do for fun? And this is, again, you see I've got a lot of family time in there. Peers are really important, but family is most important because peers will come and go, but peers are important. I don't underestimate that because it can have such a big influence. And introducing the social media information as well is really important here around activities, how much time, I'm not my kids have grown up, so I used to know all the games that they used to play. So, you know, it's good to have a few games up your sleeve, like Fortnite or whatever else they're playing. Often our older adolescents are not playing Fortnite, it's the younger ones. But to have a few of those tricks up your sleeve, no, you know about that. So it's quite good. And just about experiences on social media platforms. Make it an opportunity to you know, that you it's a really important part of their life is social media. Depending on your age, of you people who are listening to this, it might not be yours, but it is theirs. And again, it's our assumptions. We might think it's not a good thing to be on, but what we've seen is some emerging evidence that it's a de-stress mechanism for them to talk to their friends on social media or to play a game that distracts them from something that's upsetting them. So it's regulating their emotions, which I think is fascinating. There are some great resources online, which is another session that you can use to help them. When we get to the harder questions, it's sometimes good to put it into the third person. And like, this is a whistle-stop tour through heads. I'm sorry about that, but I think it's really important. Some of the strategies that work really well with me is saying, oh, some of the young people I meet have experimented with drugs and alcohol. Do you know any of your friends tried it? And it gives you that opening to what they tried, and then you can add in, have you tried them as well? You know, so it's just a gentler way in, a segue in that isn't quite so direct. And then you can ask what they use and how often they use. And they're usually pretty good at sharing that and why they use. I think it's really important to understand that. Sexuality. Oh, and just around this, I used to put smoking in there, just around that. When I get these young men who go, oh, I'm going to play first 11, whatever, is it rugby 11 or is that cricket? Sorry, I'm not a great sporting person, but, you know, and then they're smoking. So I go, so you're smoking and you're drinking, but you want to be in the, you know, top rugby team. How does that work? You know, so you start developing some discrepancy about what their behaviour is and what they want to do and what their goal is and what their behaviour is. And again, there's lots of work around motivational approaches to address that, but it's creating a bit of an opportunity and a segue in. Sexuality, do you have a partner? Are you in a relationship? Is it a sexual relationship? You know, it just leads in gradually. But again, sometimes with the younger adolescents, I'll go, did you have a puberty talk at intermediate school? You know, and it's a good way in. And what did you talk about? And what did they talk about? And it starts, we start to learn the language that they're comfortable with. So when you're talking about that, at this point, I often do ask about, has anyone ever, you know, I will ask the harder questions, and I do ask it consistently because I know that we have a high rate of young people who have experienced inappropriate, whether it be sexual behaviour, whether it be through the media, social media, or whether it's, you know, in person. So I do ask about that as well. And again, some of these questions that are really hard to ask, I just want to pose a question to you out there. I do this when I do a workshop. I'll talk to the group and say, I want you to talk to the next person about the last time you had sex. Now go. And you can see the room physically squirm. So that's what we're doing to young people. We need to frame it so it's not going to make them squirm. So leading with in a gentler way. But I think if you're uncomfortable with asking these questions, we need to ask it. We need to ask it because we know about STI rates, we know about teen pregnancy rates, although it has gone down. But you know, we do need to improve access to these sexual reproductive health services that we can offer them. Okay, how are we doing? So another area that people often find really tricky to answer around is low mood and depression, and how do you do it? Because again, the stats tell us that we do need to ask these questions, and what they also tell us, what the data tells us and research tells us, is often young people who attempt suicide have actually had a consultation or an interaction with a health professional in the last 3 weeks. When they unpick and do, you know, post-suicide intervention or post-suicide work, they've often found that they've tried to ask for help but haven't been able to articulate it. So this is a really important thing. Now, you may not know what to do, but actually at least it's out, and then you can start looking at the resources as well, because I think coming to the end of this, when we get to this, what do you do with all this information? And that's where you start working really hard, I tell you. But this is really important. So using depression is a word that they don't often use. Stress, anxious, feeling down, not sleeping are things that you can start and segue in. And I also ask about, have you ever thought about hurting yourself, or has anyone ever hurt you? And you break that down into 2 questions. I don't usually ask it as one, but it's just to try and get it in there so it's there on your radar that it's important to ask. Safety, you know, this is an important one about injuries and accidents, but also about getting into cars. And I usually have a lovely cartoon here where it says, have you ever been in the car with somebody who's been drunk? And in the cartoon, it has a picture of the principal asking the student this, and she says, yes, my dad. So this is not just about other young people driving, it's about who else is in their extended family and friends and as well. So car accidents is a big factor in, and we haven't gone into all the youth health issues, but motor vehicle accidents and accidents are high up there as in the mortality and morbidity stats for young people. Violence, no, violence I tend to weave into, you know, I'll weave it into different things because they can experience violence at school and at home as well. But it's, you know, here I put it in here, but if it comes up and there's an opportunity to do it, it's important to ask about it. But I do often ask, do you feel safe at home, at school, on the streets? You know, particularly our young people who are teetering and living in areas where there's a lot of gang pressure to join gangs, and I don't know if that happens in your area, but it's about having those frank conversations. So safety is important. Again, you could lead in around, about, you know, has anybody, you know, had a serious accident and what happened as well. Now, I do have a video here to show somebody doing a HEEADSSS assessment. We're not going to have much success with it, I don't think. So we will put that link up, and it is available on YouTube. And this is a clinician asking about social media questions and social media use. Okay, get that. So just to summarise, and these are lots of words, but generally young people are doing well and thriving, but some factors compromise those, and that's low income, poverty, family violence, and compromised mental health and addictions use from the parents or caregivers. It's a time, adolescence is a time of growth and development, and they will take risks, but having good protective factors from the PCAP model, people who care, opportunities to contribute, activities to participate in, and places to be, protects them. We do need to address their sexual health, mental health, and addiction issues as they come through. And we do know that from the global and national research that they experience more than one of these issues at a time. What we do know is we do a lot better with young people. We intervene early, which is why it's the challenge for school nurses and general practice is really important. And the best way to do it is to have a positive relationship with them, understand the factors that influence a young person on their journey from childhood to adulthood, and understand what they're likely to present with, even if they, you know, even if they don't talk about it. And knowing where to go to help yourself to get more support. So knowing what resources are in your community, whether it be your CAMP services or it might be a GP service if it's a school nurse. Another conversation is how to get a young person through to a CAMP service can be a bit of a challenge depending on which area you live in. I'm well aware of that. But I do think there are services out there for addictions and mental health and sexual and reproductive health. So you've got family planning. So know your resources of where you pass them on. So you pull your information together and you come up with a plan, and I missed that little bit, and you then work with the young person to identify what they want to do, and you hold your tongue with what you want to do until you can work alongside them to get that done, apart from if you need to treat an STI. So I'm rushing through now because it's 8 o'clock. Some courses that you can use, you've got some paid courses that we do online. The HEEADSSS path, there's HEEADSSS there, what comes after HEEADSSS, and youth health literacy, which is about how you navigate and use services for you as a health professional, and a self-care module, and also a bit about safeguarding children and young people. There's a free HEEADSSS course at the Goodfellow unit, the online learning there, and I use that as well. You've got access to one there. There's further training through different issue-based training for you to work with young people around mental health, sexual health, and AOD, alcohol and other drugs, and there's postgraduate papers as well. So there's lots of pathways if you specialise in this youth area. If you're working in an area where you see occasionally, I challenge you to give HEEADSSS a go, because it does work, and you'd be amazed what young people will share if you ask in the right way, with the right attitude, and you're open to what comes out, because sometimes it can be hard to follow up and you're left holding the baby. But at least it's a problem shared and you can start problem solving. So got some more reading if you want it, and thank you. And I don't...
Maria, you've done very well for timing.
Yeah.
Spot on. Just a comment or two. When you see an assessment done very well, it just sounds like a conversation. but it doesn't happen overnight. So it's a bit like watching practice, and peer review, and maybe finding someone in your local area who uses HEEDS and going sitting on with them with some assessments, perhaps.
Yes. So look, if you think about the areas, we don't have a lot of youth-specific services, but we do have some youth one-stop shops, YOSSs, scattered around the country. So you've got one in Christchurch, you've got Sue Bagshaw in 198, you've got 2 in Wellington, and there's a hub in Nelson as well, youth hub. I can't remember the woman's name, sorry, it's gone out of my head. But you've got Evolve and Vibe in the Wellington region. You've got Palmerston North, you've got a one-stop shop there. Kapiti Coast, you've got one. You've got the West Auckland Hub, Whangarei Youth Space. You've got some excellent clinicians who work with young people there that you can act as a resource. And honestly, I get called all the time to do case reviews, and I know that those agencies will as well, because what we want to do is make sure we improve access and provide good healthcare to get better outcomes for this population group.
Yeah. Maria, on behalf of Rural Nurses New Zealand and Mobile Health, thank you very much for your time.